we will cover today. I'm going to do objective differences between what I call Legacy Traction Splints and Slishman Traction Splints. I'm going to talk about traction considerations, even in the setting of complex trauma. So a lot of times people, when they think of a broken femur, they think isolated midshaft femur fracture, patient screaming, but femur fractures happen in a lot of different ways. So I want to expand your view on femur fracture management. I'm going to dig into that paper, the NAEMSP position statement as well, and try to get us to rethink the definitions, the binary definitions of static versus traction splinting. And then towards the end, I'll talk about the chain, what I call the chain of care. So basically the steps between the point of injury and the operating room. And then I'll go into some other future directions as well. All right, so this page, I have to do disclosures and a little bit about me. This page is entirely truthful except for this picture. So my wife took an image of me and she gave it to ChatGPT and said, clean up my husband and make it look like he hasn't been chasing our kids around for the past decade. But otherwise, I started medical school 30 years ago, 1993. I was on faculty at the University of New Mexico Hospital. That's where I started to think about traction splints quite a bit. I saw a lot of broken femurs at the time too. I did a detour. I started a nonprofit called Endorphin Power Company that's in New Mexico, and it was aimed at helping people with drug and alcohol problems. I have worked in a lot of different settings, from rural to urban, doing locums work, Wyoming, California, Hawaii, Auckland, Tasmania. This line here on Haiti relief work, this was not a long trip. I was there for, I think, less than 2 weeks, but it shaped greatly my take on femoral traction. I've invented a variety of medical devices that are on the market now. And these days, when I'm not chasing my kids around, I live in San Luis Obispo. I am considered a visiting scholar at Cal Poly, and I throw ideas out to biomedical engineering students quite a bit. And lastly, I'm a consultant CMO, Chief Medical Officer for Rescue Essentials, SAM Medical, and Hartwell Medical. So I am loaded with bias, and that's okay. These are my perspectives. I hope that some of these perspectives will inspire you to think differently about broken limbs. All right, so what do you think about femoral traction? For as long as I have been in medicine, I feel like people have been gunning for traction splints. This was in 2004. I remember when this article came out. Are traction splints an EMS relic? And it makes sense that that article exists. It makes sense that people are questioning traction splints too, because sometimes it seems like they can cause more pain than they alleviate. My perspective is, maybe there are design changes that can make things better. So instead of throwing away the entire category, maybe just improve them. If you've been in medicine long enough, you've seen similar perspectives with C-collars and backboards, masked trousers, that's redundant, masked pants, also redundant. So people question entire categories of device. My wiring is to try to improve them. All right, so this is from a YouTube video from 2018, and I'm putting this here. I know I'm mostly talking about pre-hospital. This is in an emergency department, but they're demonstrating how to use the OG traction splint, the original. This is the Thomas traction splint, and it's the first one. This is the best application of a Thomas traction splint I've ever seen. But to me, it's a little bit kooky, because if you saw earlier in the video, they had to shave one side of the leg, shave the other side of the leg, apply tape along there. Here they have steel sticking out far past the foot, tying a knot here like good scouts. And not just one type of mechanical advantage, now adding a tongue depressor windlass to add additional mechanical advantage. And it only takes 5 to 15, maybe 20 pounds to make people feel better. See, this is just, to me, excessive. So I'm not a huge fan of using this type of traction splint, especially in the pre-hospital setting. What I'm going to do right now is go through my various beefs with what I call legacy traction splints, the Thomas splint, Hare traction, and Sager splints. And these are the things that actually triggered me in the late 90s to think about ways to make them better. Starting off with the Hare traction, this is an improvement over the Thomas splint. It's adjustable. It has a little bit of a support here. There's a strap here, nice ratchet mechanism, but it's massively overbuilt. This, as I said, 5 to 15, 20 pounds of traction. This is seatbelt webbing. You can lift a car off the ground with that. You don't need that. An additional ratchet mechanism, don't need that. There's a bar underneath the leg that can cause pain. All of these straps are not critical to delivering traction. The Sager traction splint, it extends past the foot as well, sits between the legs, it's uncomfortable. So, both of these are quite challenging in confined settings. Try to put these into Stokes basket. If you have a tall patient, you sometimes may have to load the patient limb first, just so that you don't have what's called a door strike. So if the traction splint is extending out the door and you close it, that is called poor form. So traction from the foot, it's not just problematic in that it extends past the foot, it's a different dynamic too. So with traction from the foot, you have to have the person down at the foot, and it's like the medic, doctor, caregiver is doing something to the patient. Traction from the hip is my preference because you're with the patient. You can put the cord in the patient's hand and pull with them. There are numerous contraindications with both of these too. And I think that those contraindications have shaped our entire perspective on femoral traction. As I said, they're very bulky, overbuilt, and quite time consuming as well to assemble. So people don't like putting these things on. It's one of the least enjoyed parts of paramedic training. And then there's another factor. Parts can just go missing. So ankle hitches, where's the ankle hitch? And it's embarrassing. You put the whole splint on and then where's the ankle hitch? You got to go find one. I worked in a hospital where they had an adult Hare traction splint, a pediatric Hare traction splint, and then another one stored in a Sager bag with parts. And well, to me, that's kooky. Pediatric versions, both of these have pediatric versions. I think I know what pediatrics means, but do you base a decision on adult versus pediatrics on age, weight, height, limb length? When do you use the pediatric version? I want something that is one size fits all. And then they're radiopaque too. So you send someone like this through a CT scanner and you get artifact all over the place. And then really they're quite painful at times too. I have seen them cause more pain than it seems that they alleviate. There are pressure points and they're expensive as well. In Canada, the Sager splint runs more than $1,000. So there are things to improve with Legacy Traction Splints. So I'm just going to say a few things about the STSC as well as the Gen 2. I really like traction from the hip. I think it's kinder medicine. What I have done is I put the cord in the patient's hand and I say, let's pull together until you feel maximum pain relief. And I think that's just nicer medicine. There's nothing past the foot, so you can fit these into Stokes baskets. You can put them into anything really, any vehicle you like. It's one single connected device, so you're not going to get embarrassed when this ankle hitch is not attached to it. One size fits all, and I can put these on in less than 60 seconds. All right, so let's get a little bit more clinical here. Why does splinting matter? And these are my two crazy boys. It's not that they're both injured. We did a little splint training here, but well, I just like this picture. So when people have broken limbs, what they do automatically is they grab the part that hurts and they hold it tight because they are auto splinting. They're trying to hold their pieces together. That's why we put splints on, so that they don't have to do that. They will basically we try to help them hold their parts together. We want to limit pain. We also want to stabilize any clots that are forming inside of there. Potentially, we're reducing blood loss as well. With pediatrics, kids get buckle fractures all the time. And if you just left them alone and if they were reasonable people, then they would heal, splint or no splint. But they're also a warning to others. Hey, be nice to that kid. They were injured. Let's just try to tone it down just slightly. And it protects them from further injury. Occasionally they get weaponized, but for the most part, it's there to help them. All right, now, why femoral traction? Why is this a nice addition? So if you have a wound like this, a broken femur like this, these are daggers. These shards here are basically getting shoved into tissue, and all the muscle that's surrounding this fracture, it's working to shove those sharp bones into tissue. So it causes immense pain and a vicious cycle of spasm and pain. So if you can give the quadriceps, all of these muscles, something to fight against, that limits spasm, that limits pain. And it's, I think, kind medicine. Reduces potential blood loss. I don't know if it's because of the splinting or because of the traction, but it really doesn't matter to me. I'm pretty sure that if you put a traction splint on, there will be less blood loss into the thigh. Protects from further injury, assists with fracture realignment. And I say sometimes, I just don't want people to view the x-ray as a sign of success or failure. Sometimes you put a traction splint on and it's like, wow, that's perfect. The bone is right where it should be. Sometimes you put it on, pain may be better, but it may not be perfectly aligned. And there are just different forces. So that's why I say sometimes assists. And then it facilitates transport. It's just a lot easier to move somebody who is properly splinted than somebody who with their limbs flopping around. All right, so I'm going to get a little bit more granular when talking about femur fracture scenarios. So, and mind you, this is all after March. So stop the massive hemorrhage, deal with the airway, respiration, circulation, head injury, hypothermia, deal with those things first. After that, what category does your patient fall into? We think about this quite a bit, conscious and screaming, but frequently you have this, patients who they've been hit by a car, they are unconscious, maybe they fell outside of the bar, they were drunk, and they have a broken femur as well. Oftentimes you have patients that are in between. They may be conscious, but they are altered. How do I think about each of those? To go through them, I'm just going to tell a few stories. This is the very first time that I was able to use a prototype of one of my traction splints. This was in 2001. It's in New Zealand. And in retrospect, this was crazy. So this is a lawyer, and he was put into a cubicle screaming. This happens sometimes? You have a patient that is just howling in pain. He had a Hare traction splint applied. I was just out of residency. I had these prototype ski pole traction splints, and I said to him, "Look, would you let me try this?" There were no consents signed. I was just, let's get that thing off of me. So we took the Hare traction splint off. We put the ski pole splint on. We pulled the cord together, and he felt pain relief pretty quickly. We didn't do a femoral nerve block. He wasn't loaded up with ketamine or other narcotics. The traction was very, very effective. And I blurred their faces here, but this is the patient as well as his wife, and you have to trust me, but they're both smiling here. This is what his fracture looked like, and this is the splint, how it looked next to that fracture. On the other side of the spectrum, you have the unconscious and flaccid patient. So this was a patient that I had in New Mexico. It's a guy who was on a motorcycle. He took a turn too fast, and he wrapped his leg around a sign. And multiple injuries. He's unconscious. There's not a whole lot of conversation here, but how do you manage this? Well, I had the ski pole version traction splint at the time. I worked with the orthopedist and the trauma surgeon, and we said, well, why don't let's splint the ankle here. And what we did was this is plaster around the ankle. And then we just covered the open femur fracture after washing it a little bit, but not much. And then essentially just used it as a splint because they are splints first that just happen to offer traction. Two more cases here. One of them, this is back in New Zealand. I took this photo essentially to capture the absurdity of the bilateral femur fracture case where you have these two long traction splints sticking out past the foot. In this case, the support is right close to the edge. If that falls off the edge, the patient's going to be screaming. It's just really difficult to manage patients like this. It's hard to palpate pulses here. It's hard with all of these mid-leg straps to see what's going on up and down both of those legs. Try to roll the patient to examine the back. Try to do a rectal exam. It's just difficult with all that stuff. This is another patient. This was not mine. These photos were sent to me by a colleague, but bilateral femur fractures, and you can see here they're grossly externally rotated. My colleague used one of the prototypes that I left him, and it worked quite well. There's not much sticking out past the foot. You can examine the leg. The leg is splinted, and my colleague was happy with the outcome on that side. I'm actually not sure what he did on this side. All right, so how do I think through concurrent pelvis and lower extremity trauma? And in summary, it's a top-down approach. So if I have someone with a crushed pelvis, if they're hypotensive concerning mechanism, then my first step is really to put a pelvic binder on, because I think there's more risk for bleeding to death with that mechanism. Put the pelvic binder on. Do you have a suspected femur fracture as well? Okay, well, let's put an STS on. Is there injury between the knees and the toes? And do I have time to stay and play? All right, well, let's put a splint on the lower extremity. It could be a SAM splint, fast splint, evacuate splint, whatever it might be. Stabilize the lower extremity. If they're unstable, you can splint while on the way to the hospital too. But in summary, the crushed pelvis is really the most life-threatening thing to consider here. And all three of the STSs can be used despite concurrent lower extremity as well as pelvic trauma. And then for pain relief, I just say titrate to pain relief. It doesn't have to be a lot of traction, but titrate to pain relief. And then my only caveat is try to avoid pulling dirt into grossly open fractures. All right, so what does it look like to have a pelvic binder with an STS on? And this is it. You put the binder on first, and then the STSC, in this case, can go directly over it. Now, this image I put in because for most of my career, I did not know this was the case. Dr. Nick Alfonso gave a talk. He's an orthopedic surgeon in Colorado, and he had this slide, and I thought that is really fascinating. So just the act of pulling the feet together or overlapping them can be helpful to deal with a crushed pelvis. So I have a Slishman pressure wrap here, and that comes with the STSC as well as the Gen 2. But mind you, you can accomplish this with an ACE wrap, Coban, anything to hold the feet together. And just that gives you rotational stability for any injury up and down the leg. All right, now just to say a little bit about static versus traction splints, this binary discussion comes up because of the NAEMSP position statement. I would like to have people think of STSs as static splints first that just happen to offer traction, and they all go well together. All of these here, this is a box splint. A lot of ski patrols have box splints, evacuate splint, fast splint, SAM splint. All of these work well together with STSs. But I just want people to think of STSs as static splints first that happen to offer traction. Okay, I'm going to go through just a few other, I guess, FAQs. So in pediatrics, how well do these work? And it's the same. This is the Gen 2, there's the C, this is the original. There's not some number where above this age, you have to use some different product. All of these products will work on kids. Mind you, traction may not be critical on kids. They don't have as much muscular tissue there. The fight is less, but it is nice to be able to splint them here, and then you put the cord in their hand and say, hey, let's pull this together until you feel better. How's that? Okay, let's lock it in place. What about the other side of the spectrum? So what about tall people? This strap here can go proximal to the calf. So basically there's no height, 7-footer, 8-footer, you just apply it proximal to the calf. You can even go proximal to a patella, and you just have to make sure that it's snug. Some people will see this and say, well, is it okay to put neoprene there? And the answer from my vantage point is yes. And the reason is it's just very hard to make that neoprene tight. We went through a lot of different designs and tried to avoid making it a tourniquet. With the neoprene, you snug it, you can't cinch it down, you can't make it terribly tight. Not only that, once spasm goes away, then the pressure on this area as well as this area becomes less. So, no patient of mine has ever said to me, my toes feel tingling. Nobody's ever reported a problem, foot drop related to placing the neoprene there. How long can they be left on? I don't have a clear answer to that, but this relates to my trip to Haiti back in 2010. So many patients had these applied already. There were other caregivers had plastered their feet, and then they hung bottles with sand in them. So numerous patients in the hospital when I arrived already had this. A lot of the sand was just sitting on the floor, and it was just anchoring the patient to the bed. But what I did, I brought 7 splints down, I put all 7 onto patients and left them on for multiple days. And it worked great. The most important thing is just looking for areas of skin breakdown, but I never saw any skin breakdown. The nice thing in this case here is, families can get involved. All of these people around here, I taught them how to adjust and readjust traction. So, if there was needed more traction, they could do that. And now the patient isn't anchored to the bed either. All right, so the longest that I've had one of these on is 10 days. Now, if there are any orthopedists in the crowd, I'm gonna ask you this question as well. Is there any moment when skeletal traction makes sense? I've asked this of multiple people. I've never had anybody give me a scenario where it makes sense. I went to India and I brought 2 traction splints, went to a hospital, and the orthopedist said, let's change out these 2 patients. In this case, he has a pin through his heel and bricks dangling. So we took that off, put the STS on. Patient was fine. It went well. In this case, the patient has a pin going through his tibia to dangle weights also, and worked just fine. And there's another aspect of this. So if you ever have to evacuate a hospital with patients like this, that is hard to do. If you want to get out of somewhere, it's a lot easier to do if you have a mobile traction splint like that on your leg. All right, what about contraindications? So this comes up all the time. It's in every protocol when it comes to femoral traction splinting. And all of these contraindications are shaped by legacy traction splints. The Hare in particular. So this is an image of a Hare traction splint used inappropriately. So the fracture is proximal. This is a proximal femur fracture. The crossbar is acting as a fulcrum. So it's not helping this patient. Shouldn't be used there. When it comes to STSs, you can use them without having X-ray vision. If you have a tib-fib fracture, it's okay to use it. Knee injury, proximal femur, pelvis injury, it's okay to use STSs despite all of these. My only caveat is don't pull dirt back into open fractures. What about for distal femur fractures? So this is a patient that I had, distal femur, put the splint on, patient felt better. This was another patient. She fell outside of a gas station onto her knee. We weren't sure what the injury type was. Put a traction splint on, she felt better. How do you feel about hardware? So if a patient says to you, hey, I have a prosthetic hip and I think I've broken my leg, will you be reluctant to put them a traction splint? If you have an STS, you shouldn't be reluctant. You can splint that patient without any problem. You're not going to cause a problem with splinting. And if you add just a little bit of traction with them helping out and they say it feels better, that's great. I think it's not a problem to take that approach. I have used STSs on patients with hip fractures as well, and they report relief. These images were sent to me by some colleagues that I have in Europe. People over there are using them for arm injuries. So there's a broken elbow, splint it, not a problem. Midshaft humerus, splint it, not a problem. A little bit of traction helps, so be it. Our STS is radiolucent. I'm going to split hairs a fair bit here. So the only thing that is actually radiolucent is outer space, a vacuum. But in a clinical sense, does the splint obscure a fracture? The answer is no. You can have this applied while the patient goes to X-ray, while they go to CT, and you're still going to get a good view of the injury. 2 people so far have asked me, are the splints MRI compatible? And I don't think today it's a clinically relevant question. This here, the spring button, as well as this screw, nut, and washer are ferrous. It would be possible to make those non-ferrous, but today you should not use these in the MRI. All right, I did a recent training that actually shaped my perspective further. I went to a ski patrol and we did an on-site training session. And apparently, it's not infrequent for patients to run into trees when they're skiing, and sometimes they break their femurs. So what I learned from this and the ski patrol was you can put the traction splint on first before offering manual traction. Up until now, I've had this thought of, all right, apply manual traction first, then put the traction splint on, but that's not a critical thing. And then once they do feel better, then put them in an evacu splint and get them on out. Okay, so now I'm going to dig into the NAEMSP position statement and focus mainly on these highlighted areas. So I'm just going to read them off to start with. So EMS clinicians may use either static or traction splinting to immobilize suspected femoral shaft fractures. That sentence basically says these are equivalent. You have your choice. Do what you like. Traction splinting carries contraindications, additional risks, and technical complexities that are not present with static splinting. So that is putting the finger on the scale and saying, but we would rather you use static splinting. Static splinting may be the preferred method of immobilizing midshaft femur fractures in the prehospital setting. when I read that, I think they were one click from saying is. Um, I don't like these statements. I think it will lead to worse patient care. I think it's going to lead to more pain. EMS clinicians should not use traction splints unless they have reliably assessed for and reasonably excluded the presence of distal femur fractures, knee joint disruption, and comorbid ipsilateral lower extremity or pelvic fractures. I don't like that either. Basically, they're putting the weight onto the paramedic. If you choose to use this traction splint, and it happens that you don't have X-ray vision and you missed one of these other fractures, that's on you. I think that's, I think it's mean, not nice care. So I'm going to get very scientific here. This is a social media post, an N equals 1, but I'm going to read it to you anyway. I broke my femur snowboarding in 2014. They applied a Hare traction splint and holy hell did it hurt. But once traction was pulled, the relief was better than any pain meds I could have gotten. Ski patrol pulled traction, the ambulance pulled more traction, ER did x-rays, and I still had bone over bone, but the relief was there. The nurses wanted to take the traction splint off and put me in the hospital splint. Thank God my dad stepped in and did not let anybody touch that splint. They left me in that splint overnight and into surgery. I can find many other N equals 1 cases like this all over social media. Traction splints help alleviate pain. And this, by the way, is a Sager splint. You can see why this may not always be an optimal spot for putting traction splint. All right, in that paper, there is page 3. Traction splinting has been associated with iatrogenic injuries. This is a meta-analysis. It does not include something that is never going to get published, which is that STSs have no significant reported injuries. There was one where a patient's skin was dimpled. This is in Australia. The tip of the screw here was pressed up against the patient. We tell people to pad any pressure points, but the customer is always right. This screw was sticking out a little bit. What we did, we shortened the screw. And for the STSC and Gen 2, they don't have thumb screws. So roughly 15 to 20 years of existence without reported iatrogenic injuries. That's not going to get into a meta-analysis. There's another line. Worldwide incidence of femoral shaft fractures range from 10 to 21 per 100,000 per year. If your leg is the one that's broken, these statistics don't matter. But why do we talk about femoral shaft fractures? It's because of legacy traction splints. They have so many contraindications that we think of them as for this isolated, specific type of injury, when I want to be treating people who say, I think I broke my leg. Fair enough. I can put this splint on you. I'll splint you first, and then, oh, does traction help? Great. I don't have to have X-ray vision. I know that the number of people who have broken legs is a lot higher than this. STSs are splints first that just happen to offer traction. All right. A few other lines to consider from the paper. Rates of transfusion did not differ significantly in patients with various types of long bone fractures. This is selection bias. So if for 100 years people have not been able to put traction splints onto everybody that says I have a broken leg, if it has to be specific types of fractures where you put them on, then how are you going to get papers that show a significant difference? And the vast majority of people that I've ever cared for, they don't need transfusions. But if you've ever treated people with broken femurs, you've seen their thighs become balloons. And it's not that it's not urine in there, it's not helium, it's blood. And that blood is not in the intravascular space. Whether it's the splinting that helps limit bleeding or whether it's the traction that helps, I think I'll never know the answer to that, but I actually don't care because it's pain reduction that drives me more. Identifying femoral shaft fractures and comorbid lower extremity and or pelvic fractures in the field can be challenging. Yes, it can. And I don't expect anybody to have X-ray vision. With an STS, you don't need X-ray vision. You can apply it first and splint and then offer traction if needed. Traction forces should be equivalent to 10% of body weight or not exceed 15 pounds, whichever is less. I've seen these numbers for a few decades now. I think it's absurd. The main thing that I get from it is it doesn't take a whole lot to help people to feel better. It doesn't take much traction. But who can estimate body weight? My mantra is treat the patient, not the numbers. Pull until the patient says that feels good, and then lock it in place. And adjust and readjust as needed. All right, I'm not gonna read this entire thing, but unfortunately, traction splints may loosen over time. That's what they do. You have a spasmed leg, you put the traction splint on. As the spasm goes away, it lengthens and the traction splint loosens. It's not unfortunate. That's the goal. What I will do in an ER is I put the traction splint on. Sometimes I'll leave, come back, and it almost is like the splint is wearing the patient. It can be loose. And you say, hey, do you want that any tighter? And the patient says, no, I feel okay. You can teach them to adjust and readjust very easily, but it's not unfortunate that they loosen over time. And then this line, long devices may present challenging when packaging patients. That applies to legacy traction splints. STSs don't extend past the foot. I'm not going to read this whole testimonial here, screenshot it if you like, but it's just a nice recent use of an STS.
Okay, here I'm just going to demonstrate use of the STSC. Take the distal strap, neoprene, and apply it just proximal to the calf. Extend the middle tube from the outer tube. I like to put the groin strap behind the knee and then sort of scissor it up, then click it in place. And then the last step is apply traction. Probably want to go a little slower than that on actual patients. Lock it in place. I can do that faster than I can static splint patients.
All right, a little bit more on the paper. There is no other mention of an STS in that position statement paper, that meta-analysis, other than this. In the references, the STS had the best objective performance during testing and the highest subjective evaluation by participants. Along with its ability to be used in the setting of associated lower extremity amputation or trauma, this splint is the most suitable for battlefield use of the 3 devices tested. That's from a paper in 2014. That's the only thing that's said in there. Nothing else negative in the paper. But there is one paper that was not included in the meta-analysis, and which is this one here. So, can a level 1 trauma center in New York City improve pre-hospital care? There's backstory to this. So in 2017, New York City Fire Department adopted STSs. They've been using them. I have not had reports of things going bad. Nobody is saying to me, let's get rid of these things. Why are we still using these? The results of this are, and I'm paraphrasing here, but educate, train, and increase use of traction. All right, so screenshot this if you like. These are objective differences between various traction splints. I'm not going to read this whole thing to you, obviously. I will say a couple points here regarding the Sager. Useful for bilateral femur fractures. That is fair enough, but the Sager costs more than double either a Gen 2 or C. So if you're really concerned about bilateral femur fractures, then you can buy 2. It also has a numerical tension gauge. I think that is a false feature. I've never had a patient with a Sager splint come in and I say, let's dial it to 11. That it's just not how I like to treat patients. I'm going to pull traction until they say, I feel better. All right, so I want to just say a little bit about evidence-based medicine. And, you know, people, it's like a religion for some, and it's not unreasonable. It's nice. We all want to practice evidence-based medicine, but there are lots of different types of evidence out there. I think a lot of people equate evidence-based medicine with literature-based medicine. And under LBM, you have testimonials, case reports, abstracts, and meta-analyses as like the most important, most helpful. But meta-analyses are biased as well. What meta-analyses miss are recent advancements. So if you look at 100 years of papers, you're not going to necessarily focus on the most recent things. I actually wrote to the author and NAEMSP about STSs, and the author was aware of STSs, and he said, I agree, you have some compelling points. There are some aspects of STSs that are great, but you need more published literature. The catch for me is anything I publish or try to publish is biased. So part of this talk is to try to inspire other people to take some of these things I'm saying and research them and put pen to paper, good, bad, or otherwise. Tell me if you have iatrogenic injuries. I want to know so I can improve these things more. But if you just rely on literature-based medicine, that's a blinder. When things are obvious, people also don't publish. So nobody's going to publish an article that says a spoon will feed me cereal better than a fork. Things that are obvious often don't make it into the literature. I will admit I live in this land and this land an awful lot more. So I have many ends for traction splinting, and this has shaped my perspective on traction quite a bit. I've done a lot of personal experimentation too. Both, if you I have a YouTube channel where I put up little kooky experiments with my kids sometimes, and done a lot of experimenting to try to get to the bottom of how these things work. There's another category of evidence, which I think is how most of us practice. It's other people-based medicine. So when I finished residency, a lot of my learning was from emergency medicine abstracts. I would go into summaries and I would EM abstracts, EM rap, that sort of thing. So that shaped quite a bit of who I was. I couldn't read all the articles. Nobody can. So you learn from social media. That's dicey sometimes, but that's how a lot of people do it today. And then webinars. I'm going to say just a few other things here. So on the topic of chain of care, this is what's happening from the injury to the operating room. The world that I want to live in is a traction splint gets applied in the field after somebody is injured, and it's left on all the way to this point here. Every time you adjust something, patients hurt. But frequently, paramedics will take a patient with a traction splint, they bring him to the ER, and then they'll loiter, they'll wait around to get their traction splint back because they want it back. They may not get it again, and so they want their splint back. And the ER will sometimes put a traction splint on. Sometimes they'll use orthoglass. Frankly, we'll do whatever the orthopedists tell us to do and put that on and then go to radiology. Sometimes splints have to be changed just to have a good CT scan. I had an email recently to that effect. I think it was a Hare or maybe a Sager splint, but somebody had a traction splint on. It caused too much scatter in the CT, and they were looking for any splint that offered less scatter. And then from here to the operating room, there might be another. Someone may come at you with a drill and put a pin through to dangle weights. I think it's crazy. I think put an STS on here, leave it on all the way to the operating room or maybe to the floor while they wait to get to the operating room. That's the world that I would prefer to live in. So in the future, what I really hope people will do is treat patients who say, I think I broke my leg, and then feel like, okay, I can put an STS on that. I don't need to have x-ray vision. There aren't contraindications that will get me dinged. I'm going to put the splint on, pull to traction, give a little bit of relief if it helps. I would love it if EMS physicians, ER docs, radiologists, orthopedists, I wish they would all collaborate and decide on a path, because people aren't on the same page for traction splinting in general. Until somebody says to me some compelling reason to put a pin through somebody's leg, I'm going to continue to think that pinning is crazy. So maybe there is a scenario where it makes sense. I haven't seen it yet. I'm going to wrap up talking about something that may be relevant to some of you today, traction as an option for chronic pain. So this is during COVID years, 4 years ago, roughly. A neighbor of mine, name is Larry Hazen. He found out about STSs. I gave him one, he put it on his leg, and it helped him with his chronic knee and hip pain. He's used it on patients of his doing physical therapy. Traction can be helpful. It's just a nice thing. And this is N equals 1 here. N equals 2 was, I gave a talk a couple years back about traction. This is my friend Carson, a wildland firefighter. He got crushed by a tree years back, and he had chronic SI joint pain. And at the end of the talk, we put the traction splint on, and he felt immediate pain relief. And it continued to help him until he actually had surgery that resolved the problem. But I think there's this entire world of people who deal with knee, hip, SI joint pain that can be relieved with actually a simple mechanism. So right now you can take handfuls of ibuprofen, you can take narcotics, you can have your knee injected with steroids, maybe stem cells, you can have surgery, or you can own this device and adjust and readjust traction from your couch at home anytime you want while watching Netflix. I think that that's a paper worth publishing, but it can't be by me. I'm hoping that somebody else will take interest in that. And it's not just N equals 1, N equals 2. There are other papers in the physical therapy world that suggest this as well. This is the Korea Society of Physical Therapy. Knee joint traction therapy was effective in improving pain, physical function, and depression in patients with degenerative arthritis. To me, that's compelling. As far as adoption goes for these traction splints, New York City Fire Department, Dallas, Boston, LA County. It's endorsed by National Ski Patrol. Most of Australia are using STSs. So I think this is not just a new product on the market. I'm hoping that people will take interest in it and consider publishing. So I really appreciate you sitting through this. And if you ever want a free training for your agency, I'm happy to help. Email me anytime. Call me. I'm here to help. So that's the talk. Oh, wait a minute. Yeah, these are two videos you might want to be watching related to STSs.